Hello. During this talk, we are going to be discussing the most common etiologies of infectious diseases that are associated with the cardiovascular and lymphatic systems. So what I would really hope that maybe some of you would do would be to actually open up your etiologies of infectious diseases that are separated for you by groupings and kingdoms and as I said, groups, and then you can follow along as we encounter those particular agents in our discussion of this particular topic. So when we think about the cardiovascular system, we understand that it's composed of not only the blood, in our study of blood, hematology, but also the heart, and then those vessels that the blood is flowing through, being pumped by the heart through, which is a closed system. So this is providing all of the oxygen, all the nutrients, all the dispersal of hormones, the sending of antibodies to sites that we need, all of those important cells that protect us. This is sending those to our stationary cells and tissues, which most are stationary. So we need this liquid tissue that we call blood being pumped to all of our tissue origins, because without it, after a length of time, and not very long length of time, those tissues will start to die if blood is not available to them. So they carry away waste products like carbon dioxide and waste to be filtered out of the system. When we think about the lymphatic system, this is an entirely another vascular system that is right next to the vascular system. So when we think about arteries, which we know carry blood away from the heart, and we think about veins, which we know are the vessels that carry blood to the heart, we understand that there's also vessels that are running parallel to both of those, called the lymphatic vessels. So what do the lymphatic vessels do? They actually are going to be circulating the lymph. Lymph is a fluid, a clear fluid that has bathed our tissues. It's going to be returning that back to the blood, the cardiovascular system. So lymph is a liquid mostly water, very similar to plasma, fluid that bathes all of our tissues, and it circulates through our tissues back into the lymphatic vessels, which then transport that lymph through nodes, which are small little tiny organs, if you will, that filter the lymph before it can be returned back to the cardiovascular system. It is going to be being returned back here in the subclavian vein. So as the lymph is bathing all of our cells, all of our tissues, and moving along these vessels, moving through lymph nodes, it eventually, the word dump sounds sort of non-glamorous, but it does dump the lymph back into the cardiovascular system, our blood, back to the blood. So it plays a huge role in regulating also blood volume, you can imagine. So all of these have to be balanced. So that's just a quick review of the anatomy and physiology of these systems, and I think that most of you have had anatomy and physiology, so you sort of understand that. The pump itself, the heart, it's really not a pump, it's two pumps. The right pump, right atria, right ventricle, is receiving blood through the superior and inferior vena cavas that has been in the system, delivering oxygen, picking up waste, picking up CO2, coming back to the right side of the heart, where the right ventricle, as soon as the right atria sends it to the right ventricle will pump it to the lungs through the pulmonary artery. In the lungs, CO2 will be dropped off, oxygen will be picked up, and it will be returned to the left pump. It's really two pumps working in synchrony. The left pump includes the left atrium and the left ventricle. And this blood, once it's in the left ventricle, this muscular, which is the thickest muscular part, this left ventricle will contract, sending it to the aorta, which will send some above to the heart, to the head and the upper appendages, and through the descending aorta down to the lower regions of the body, again, to deliver that oxygen it picked up in the lungs and to pick up CO2 and then come back to the right to do it again. So really two pumps, a right pump and a left pump working in perfect synchrony. When we think about this organ, we do think about this middle myocardial muscle layer that has to be functioning, has to resist fatigue, needs to be rhythmic, and we understand it has a little area that is referred to as the SA node, the sinoatrial node, which is the pacemaker of the heart here in the right atrium, and it sends that rhythmic system, firing system, as a pacemaker of the heart to keep the heart beating in rhythm. The tissues of the heart, we understand the endometrium is lining, the endocardium is lining the chambers of the heart. The myocardium is the muscle layer, and the epicardium is that layer that's the outermost layer of the heart. The heart itself is in a sac, and that's not shown here on this illustration, but it is a very tough fibrous sac called the pericardium, and this pericardium can also sometimes be attacked by viruses and or bacteria and or even fungi. So any of these layers, these tissue layers, the muscle, myocardium, the endocardium, the epicardium, or the pericardium, are at risk for some infections, and we would call that pericarditis, epicarditis, myocarditis, and endocarditis. That's what that would be referring to. And if there were inflammation of any of those layers, then you have to figure out what the etiology is that's causing it. So that's what we're going to kind of look at. We do know arteries carry blood away from the heart. This is kind of a typo from your textbook. In the left side, it is oxygenated, but the pulmonary arteries that are taking it to the lungs are actually deoxygenated. So this is technically, sort of splitting hairs here, but this is definitely a little bit of a misnomer there. Arteries carry blood away from the heart, the ventricles contract, and those vessels that take that pressure from those ventricles with the blood entering are called arteries. Veins bring blood to the heart. So, and again, this is from your textbook, but it is actually incorrect. The veins that are on the right, bringing to the right pump, do have deoxygenated blood, but pulmonary veins that are bringing blood to the left atrium, that's oxygenated blood. So this is an example where sometimes texts don't really get it right. Textbooks really don't get it right. But anyway, that's back to the basic anatomy and physiology of the heart, and I hope you all learned that during your anatomy and physiology studies. Capillaries are those vessels that are going to be one cell layer thick. They are so small, they are microscopic. They're so small that red blood cells are moving through them single file, and these are the beds, the webbing, where as blood is moving through, the membranes that separate the capillaries from your tissue spaces are so thin that you can have rapid diffusion of gases, rapid diffusion of solids, rapid osmosis of water if it needs to be moving, and waste can come back in to the blood to be picked up and carried to the lungs to give off CO2, to the kidneys to give off other waste products that are being monitored. So when we think about the capillaries, we understand that in our cardiovascular system, these capillaries are microscopic, and every tissue source that we have, all of our different organs that are made up of tissues, and tissues are made up of cells, all of them have designated capillary beds where blood is running through in a closed system and delivering nutrients, delivering fluids if needed, picking up waste products, and then in a closed system coming back through the veins to be carried back to the heart. Okay, so that was a little bit of the anatomy, just a quick review. We understand that the cardiovascular system is very much protected. It is a closed system. But the microorganisms that have the ability to invade it have the ability to invade every part of the body, because that liquid connective tissue we call blood is being sent throughout the body. So you can imagine that this is a very dangerous situation when we hear about bloodstream infections. These are systemic. They're going to affect almost every system. So we have a lot of defenses built in to our cardiovascular system. There are about 5 to 10,000 white blood cells per microliter of blood. That's a normal range. If there is an infection, we will see these numbers go up because the body will respond typically to that. And we understand that there are many different kinds of white blood cells. Different white blood cells that respond to different types of stimuli. Neutrophils respond to bacteria. Lymphocytes respond to viruses. Eosinophils respond to, these are all white cells, eosinophils respond to parasites and allergies. So monocytes are going to respond to any of those that I just listed, and they act as like the big eaters, the dump trucks, the cleaning up of debris when there's been fallout from infection, where tissues have been damaged and cells are dying. These monocytes are very specialized in that they're going to clean up the area. So they're called big eaters, macrophages. So we understand about innate and adaptive immunity, and we understand that we're born with natural protection, but we also understand they're very specialized types of lymphocytes that are for adaptive immunity. Whenever we encounter a foreign antigen, we are going to build a specific, that's what adaptive means, a specific response to that particular foreign antigen, and often, if we can survive the event, we're going to have then lasting immunity or protection against it. So we have a ton of built-in innate and adaptive responses, and we understand that when something does get into the bloodstream, this can be a very serious thing. The suffix "emia" means in the bloodstream. That's what it means, involving the blood. So viremia, viruses are actively dividing in the blood. Fungemia, this is for fungi, yeast, and or molds. Bacteremia, the presence of bacteria. I want you to note that these say presence because they do not necessarily mean that they are growing. Okay? This is an important distinction. So even though we may sometimes see bacteremia, which we know can happen, if you can see blood because of an injury, even if you've picked at a bump or you've flossed your gums too hard, your teeth too hard, and now your gums are bleeding, or you stump your toe, or you have, heaven forbid, a huge trauma, and someone's bleeding out, it means that microbes could be entering. If blood can be exiting, then microbes can be entering, right? So every now and then you will have a bacteremia that does not mean septicemia. Septicemia is when they are growing and flourishing, and it's not just bacteria. Septicemia can sometimes be because of fungi as well. So that is what septicemia means, and people refer to this as being septic or having sepsis. If it is serious enough, if those microorganisms that are causing sepsis are, if the body is not responding as it should and you're not getting the treatment that we know we can control this with, then this can end up leading to septic shock, which is going to be a rapid cascade event that can lead to death. The shocking thing, and you can see some of these numbers, but the shocking thing about sepsis is that many times, even with the best medical care, even immediate medical care, you can see mortality rates up to 50%, and that's with best medical care. So this is a very serious thing. All right, we do think about these systems as being closed, which is kind of protective for us. So when we think about that, we understand that the Human Microbiome Project, which is trying to look to see what are all the different organisms that make up these different sites, like on our skin, in our nose, in our GI tract, the areas that we know to be colonized with these microorganisms. We understand that, but that there can sometimes be these transient microorganisms, but we don't really think about them as actually staying there. So we do essentially think of blood as being a sterile body fluid, and we kind of hope that the lymph will eventually, as it gets cleared through those lymph nodes before the lymph fluid gets returned back to the bloodstream, that it's also been sterilized and or cleared, because the lymph nodes are little aggregates of those very special white blood cells, lymphocytes and macrophages, that are cleaning out the lymph. So even if you had a splinter that introduced microbes to tissues, right, the lymph, as it's moving through the lymphatic vessels, and it has some of those microbes in it, each node that it goes through is taking them out. So by the time it gets back to the subclavian vein to be returned back to the bloodstream, which contributes to blood volume, it's clear, it's sterile. So we really kind of think of it as being that way, as being sterile, and no normal flora is the thing for that. Now, I just think this is just FYI for you all, but this is just absolute evidence of how public health initiatives are so important. Public health initiatives like immunizations projects and that sort of thing. In 2002, a partnership between all the developed governments got together, and even with private sectors and the communities, to fight against HIV, human immunodeficiency virus that can lead to AIDS, doesn't always, but can, the bacteria that causes tuberculosis, which is Mycobacterium tuberculosis, genus species, and malaria, which is caused by Plasmodium, and like 5 species of Plasmodium. They got together and united and designed some protocols to fight against these particular infectious agents. And since then, there's been, a significant reduction in deaths associated with these big 3 diseases. So, this is the good news about when communities, even if you think of communities as being countries, communities coordinating their efforts for public health for one humanity, for a positive outcome of one humanity. So this is like a good news thing. Now, let's go ahead and talk about some of these individual microorganisms that can cause disease within these systems. Malaria is caused, as I said, is caused from a protozoan. The protozoa is called, the genus is Plasmodium. There are 5 different species that actually contribute to this one disease that we call malaria. And we understand that this actually doesn't just threaten very isolated countries in Africa, say. It actually threatens a significant 40% of the world's population every year. So I really want you to think about that. It was actually called that because, way back before we understood that it was a protozoa that was causing that, people that were very much affected by the deaths and the devastation that this protozoa can cause, they knew it was coming from something in the air, so they called it bad air, which is literally what malaria actually means. You can look through some of the signs and symptoms of malaria and what it actually does, but I think when we look at what is causing it and how the progression of that protozoa, what it takes for its life cycle, you would see why these signs and symptoms are actually occurring. Again, there are more than one species that actually cause malaria. That this falciparum is one, Plasmodium falciparum is one, and it has a very high mortality rate. It's one of the worst mortality rates with this, because what it can lead to is the red blood cells lysing. And you can imagine red blood cells should not be lysing and spilling their contents into blood plasma. If that's happening, that's going to have widespread effects leading to kidney failure and spleens rupturing, and it's systemic is how this is going to end up happening. So you can even have cerebral malaria, which is another complication of that genus Falciparum, Plasmodium Falciparum, and so then it can again lead to oxygen deprivation in the brain, which leads to coma and then eventually death. Some of the other species, Vivax, ovale, these are ones that have a mortality rate associated with them, but they're lower. But what they can do is stay in the body and have relapsing types of problems happening because of infected liver cells and then these dormant protozoa that can last for even years. So let's just take a quick look at this. This life cycle includes two hosts. It includes the Anopheles mosquito and the human. Okay, so we could get rid of the disease if we got rid of humans. That would be done. But we don't want to get rid of humans. So what we've done in the past is try to get rid of the Anopheles mosquito. And maybe you can imagine how difficult it is to get rid of mosquitoes. Some of the techniques that we've done to try to limit the mosquito infestations in areas that are having outbreaks of malaria, what we have used, the pesticides we have used, have been so awful that they've affected the ecosystems in those areas. So decades ago, when we were using chemicals that were so toxic that were controlling the mosquito population, but then were wreaking havocs on ecosystems in those areas, that didn't quite work. So now there are other things that are going on to try to limit these mosquito the mosquito populations, things that are actually targeting the genes of the mosquitoes. So making the males sterile. These are techniques that are actually being done now and actually having some positive effects in trying to control the mosquito populations. Now, we can also try to do things to keep that mosquito from biting humans. The thing about the Anopheles mosquito, the ones that bite humans are the females, and the females only feed at night. So what happens is, if we can protect people at night from these female mosquitoes, these are also things that can help to limit the spread of these diseases, and this has been incredibly effective. So in areas where there's high amounts of malaria and malarial deaths, which are by the way, to children, they're putting screens on windows and doors, providing nets to sleep under. That has been an amazing way to help to prevent the spread of this disease and to help to reduce the numbers of deaths. So nets to sleep under, clothing, and then some not so harsh chemical spray to spray your skin to try to prevent this bite from this female mosquito. So as the female mosquito bites, she is delivering this protozoa into the bloodstream. It moves to the liver, and as the liver is a filter of our blood, so many of the red blood cells are becoming infected by this particular stage of this protozoa, and then they're completing their sexual part of that stage when the female mosquito bites again and picks up some of those. So it is this, it has both of these hosts that are required for the cycling of these protozoa, Plasmodium species. So you will see that on your etiologies list under protozoa, the kingdom protozoa, which is eukaryotic, and you can read through some of the things that this is actually doing. So looking at the deaths, it wasn't that long ago that we would see 1.5 to 2 million dying annually. Again, it was usually children and young adults in these affected areas. It's important to understand that it's not just an African issue, that actually in the 40s, even in Charlotte County, Virginia, Southside Virginia, there was a malarial outbreak. So many areas have been exposed to this in the past. But you can see some of the distribution here. It's near the equatorial regions because the equatorial regions are hotter, they're moister. That moisture allows for these mosquitoes to flourish, and as they flourish, they have the ability to transfer this protozoa. You can see the red blood cells that are infected here in this particular illustration that you're seeing. You can see almost every red blood cell has been affected, and if the red blood cells are infected with these larval stages, trophozoites and merozoites, then they cannot function. And as these red cells cannot be delivering the oxygen to your tissues, it's systemic and how your reactions are going to be to this disease. So again, nets, this has played a huge role in limiting and reducing the numbers from up to 2 million not very long ago to now 500,000 deaths annually, which still sounds just unbelievable to hear that many. But it was cut and by more than half with some of these practices that are going on now to try to prevent this. So malaria is still a disease that we really very much worry about. And just last year, there is a pilot vaccination programs happening in the African countries that are the most affected by this. So we will be listening to hope that this is going to help, again, save lives, and hope that is going to work. The treatments, as you all learned in Chapter 10 when you were looking at chemotherapeutics, the treatments have to be antiprotozoal, like chloroquine, quinine. These are all very toxic, low therapeutic drugs, but because we know that protozoa are eukaryotic, and the treatments that will affect those cells can often interfere with our own cells, making this a pretty toxic type of drug to give to the human with a low therapeutic index. So we're careful in how we give these drugs, and we make sure that we know what we're treating. Again, so important that you know what you're treating so that you are not doing harm with your treatment. We saw that during this past pandemic, people who were misinformed or maybe even intentionally being disinformed were being told to get for a virus that caused this pandemic, the CV2 virus, SARS-CoV-2, were being told to take hydroxychloroquine for that. That is so toxic. So these people are sick, and at the same time, they were being told by non-scientific, non-medical community to ask for this drug, and this was causing harm at the same time that their bodies were trying to fight off a viral illness. They were having to deal with the consequences of a very low therapeutic index toxic drug. So that is what we do know or treat. We use combination treatments for people with malaria and protozoal diseases. Another disease we think about is HIV, human immunodeficiency virus. This virus, just because someone is positive for this virus, does not mean that they will necessarily develop into full-blown AIDS, acquired immune deficiency syndrome, which you should know what both of those abbreviations stand for. The symptoms of HIV are directly tied to two very important things, and that's the level of the virus in the blood and also the level of the T cells that are in the blood trying to fight the virus, right? So these two things are very important. What we would like to see, the people that are doing the best that are HIV positive have very low, sometimes even undetectable viral loads in their bloodstream, and they're continuing to keep their T lymphocyte counts up. So those are the people that are doing the best. But people who end up becoming ill and symptomatic of having HIV positive status, going into AIDS-related complex, ARC, AIDS-related complex, which can then lead to AIDS, full-blown AIDS. The initial symptoms when they first encounter this this virus are usually pretty mild, and many people actually miss that part because they are flu-like symptoms. So when you have flu-like symptoms, you often think, okay, I have the flu, and then that becomes better, but then it can actually be weeks, months, even years later that enough of the virus is causing enough damage to our T lymphocyte counts, reducing them, that now people are picking up opportunistic diseases. And those opportunistic diseases are the ones that don't affect people with healthy immune systems. But because this virus in particular can attack the T lymphocytes, it's reduced those numbers so much that now people can't fight off normal things that they encounter as part of their microbiomes and or encounter in their ecosystems that shouldn't be causing them to get sick, but they do. And they get sick enough that those particular infections can be sometimes the last infection they have in this life. So, fungal pneumonias that have a significantly high mortality rate, or fungal even meningitis or encephalitis, or even viral encephalitis or meningitis, that can be some of the last things that can end up taking them out when they have this disease. It's really important to look at the defining illnesses, because sometimes people don't know their HIV status and they may not know that they have this, but when they come in and they see these infections, these are infections that should make a medical professional question HIV status. So if somebody comes in with a fungal candidiasis, Candida albicans, trachea, bronchia, lungs, or herpes, and herpes simplex is very common, human herpes virus 1 and human herpes virus 2. But most people, when they have that, have a limited local infection and, it resolves. But if they get it, that ends up becoming systemic, a pneumonia, or a meningitis, or then it means that person's immune system did not do what it's supposed to do, and you need to question whether that person's immune system is compromised due to maybe now going into HIV positive status that is going into AIDS. So typically what we see, these are very common things that we see in people who are immunocompromised, especially people who are now going into AIDS. So people should be aware of these. Now, it should also be noted that just because somebody might have chronic cold sores, do not believe that they are, people can have chronic cold sores and not be HIV positive. So I don't want you to think they're mutually exclusive. They're not, anyway, but those are things that we think about. This is a virus. It's a retrovirus, so human immunodeficiency virus. You should understand that. And the treatments are typically going to be targeting a couple of different ways the virus attacks. Some of the treatments are actually going to involve preventing the attachment of the virus to the cells, so trying to interrupt that. Some of the treatments are going to end up trying to interfere with a viral replication once it's inside of the host cell. So there are many different mechanisms to try to control this virus, and many of those treatments are actually working. So now people with HIV positive status, many, not all, but many, who get diagnosed early, who have early treatment and consistent treatment, they can live a normal lifespan. So this is again wonderful news, right? So something to be thinking about. How HIV infects, it requires a significant viral load, and it has to be through direct fluid contacts, and not all fluids are infectious. So it is rare to never that you could get it through saliva, right? But there are other fluids that it's very likely that if you share those fluids or get in contact with those fluids, that you could maybe acquire this particular virus. So it infects the T helper cells, the T4, CD4 cells, CD4 cells that y'all have learned about with me. These helper cells, actually our entire adaptive immunity, our entire specific immunity hinges on them. And they're involved in some of the non-specific innate immunity. So it's essentially by attacking these cells, specifically the CD4 cells, this is what cripples your immune system. But it also has attachment sites for other types of white cells. So again, just a very devastating virus because of the cells that it attaches to and can decrease in number. So that's the only other thing I was going to really make sure I stress to you is the idea of how it's transmitted. It can be transmitted through any sexual type of intercourse, oral, vaginal, and any anal, any type of sexual intercourse. It can be transmitted to fetuses through the placenta. So we understand that it can also be transmitted that way. Again, why it's really important that pregnant women who are HIV positive start taking treatment immediately. There are a lot of numbers that you can, I think I have them in here, that you'll see how much it greatly reduces the chance of transmitting it to your fetus if you are being treated. And so that's a good reason to be tested. But anyway, breast milk has a significant number of white cells, and so this is why breast milk of HIV positive women, they should not breastfeed. We understand that this is a major route of transmission of this virus to newborns. Even if they missed it as a fetus, somehow missed it as a fetus, if they're getting breastfed after they're born, this is a major way of transmission. Again, it cannot be transmitted through kissing, through saliva, through that sort of thing, but it can be transmitted through other body fluids. So just something to look at and be aware of. Health professionals don't really have to be, well, health professionals consider everybody that they treat to have everything. That's called universal precautions. You treat them like they have everything. But HIV is less of a concern, really, than like hepatitis B virus, because HIV doesn't live very long on inanimate surfaces, and it requires a certain amount of it to be exposed to before you would actually even get disease. So since it doesn't live very long on inanimate surfaces and whatever, we don't have to worry about that as much as we do hepatitis B. But all health professionals treat everybody they encounter with universal precautions, so being very, very careful with that. This has given you some of the numbers suggesting untreated mothers have a very high percentage of transmitting this to their fetuses, but evidence supports that if someone's getting treated while they're pregnant, that is reduced greatly. It isn't down to zero, but it is reduced greatly. This was an interesting little, I think just an interesting little statistic there about, of course it was mandatory, but people hate that word mandatory. Mandatory to do the right thing, right? As far as public health is concerned, to control the spread of disease and to try to limit unnecessary deaths. But just to get back to that, since I highlighted it, Cuba, which does require mandatory types of things, they eliminated the mother-to-child transmission through testing and through treatment. That was required. That was mandatory. Mandatory is not always a bad word. So again, having HIV positive status is not the same diagnosis as having AIDS, but anyone who has an HIV positive status will be potentially infectious for anybody that encounters their particular body fluids. If somebody has had a behavior that has put them at a risk of potentially acquiring this particular disease, it would be really important that when they get tested, they should understand that it may take up to 6 months later after the event to actually detect a positive status from that event. So what I'm saying is, if you get exposed to what you think could have been a potentially positive fluid, you can be tested soon after, but you can't really rely on that negative result. You'd have to be tested as far as 6 months out from that event to be assured that that event did not cause you to have HIV positive status. So during those months, though, that you were testing negative, you could still be giving that infection to someone else. So you should take extra caution. Well, I would just take caution anyhow, but anyway, extra caution to understand that even though it's non-detectable, potentially non-detectable by our testing methods for 6 months, you could still be infecting someone. So that's a very important thing to be thinking about and to educating people on with that. So you can look at some of these. The numbers for CD4 cells below 200 cells per microliter would indicate that you are in full-blown AIDS at that particular point in time, and it would be a terminal illness at that point. So really, the way to prevent it is avoidance of these body fluids with infected people. So sexually active individuals really should consider everybody that they encounter as infected. Really. So unless they've proven otherwise, and the only way to be proven otherwise, this is from your textbook, by the way, is that you well, I don't know how you ever prove monogamy, but after 6 months, not monogamy. After 6 months, and then it would be barrier protection's always important. Avoiding certainly intravenous drugs, sharing needles, that sort of thing. These are all important things. There is no cure for HIV. We do not have cure. We're still working on potential immunizations. This is a virus that evolves rapidly, and we understand that it does. So I had spoken to you. I'm not going to name any drugs here. Or even ask you in this particular section, though you had that in a prior chapter. But it's just important to understand that the drugs of choice are usually going to be targeting at least 2, sometimes more than that, areas of how this virus actually infects and replicates itself. So endocarditis is our next one we're going to talk about. This would refer to inflammation. Inflammation of, itis means inflammation of the endocardium, the inner lining of the chambers of the heart, which includes these valves. So this can either be acute or subacute. Acute would suggest that the symptoms come on rapidly and they're pretty serious. Both of these are serious, but anyway, that's how the symptoms occur. Where subacute is more of a chronic, subclinical kind of presentation, but again, both of these are serious infections. They can be from viruses, they can be from bacteria, they can even be from fungi. Some of the symptoms, as you can imagine, since the heart is our pump, really 2 pumps, but since the heart is pumping blood through this closed vascular system, anything that compromises how blood is moving would compromise how well we feel. We'll be tired, potentially fever, our body's immune system responding. The fluids, how they move between compartments from plasma to lymph to cellular, back to lymph, back to blood volume, controlling blood volume, the blood vessels, can lead to edema. It can actually lead to, lysing of red cells. So all of these things, the heart can become arrhythmic, and it can feel very similar to a myocardial infarction when this happens, which is what the medical term for a heart attack. So sometimes we understand the liver is also trying to filter out, and the spleen, so there can be abdominal and side pain when we think about where the spleen is and where the liver is. So we understand this. These are some lesions and Osler's nodes that we think about. These are just, I don't ask you these, but these are things that you might hear about when there's suspicion of endocarditis. Whenever there's something that can reduce for long periods of time oxygen levels to our extremities, then we can start to see, it takes long periods of time, we can start to see clubbing at those sites because those tissues are actually at those extremities suffering from low oxygen. So even on a macroscopic level in an evaluation, you can notice that. We see these in chronic respiratory diseases as well. Again, from lack of oxygen to those extremities. Acute endocarditis, if it's bacterial, we understand that these vegetations can actually be growing on those valves, and it can, this is kind of a devastating thing. I've seen autopsies of hearts from patients who have died of this, and their valves are just completely vegetated, like they almost look like agar petri dishes that are growing colonies of microorganisms that you can see without the use of a microscope. Some of the bacteria that we think about are going to be Staphylococcus aureus. This is for acute endocarditis, but we can see others as well. But this for acute, this is what we tend to see. Parenteral is directly entering into the body through drug use, contaminated needle sources and or trauma due to injuries like accidents and or surgical procedures where the Staph aureus has taken the opportunity to invade and cause an acute endocarditis. Subacute, still serious, but signs and symptoms are a little bit more vague, a little bit less obvious. This can be because of biofilms of microbes that are growing, impeding the function of those particular tissues. We tend to see subacute with people who have some underlying conditions and or history. So maybe they've had rheumatic fever as a child, or some sort of situation as that, where we see that they're the ones that are going to be the most at risk for subacute. This is often from a group of bacteria we call Enterococci. These Enterococci, I should actually really label that for you. Enterococci, which are equal to alpha hemolytic strep. And in this group of Enterococci, what belongs to that group, some genus and species in that group, are Streptococcus sanguis, Faecalis, Faecium, Oralis, mutans. Many of these are actually part of our normal flora in our oral cavities. So we understand that our normal flora really does contribute to sometimes causing problems in cardiovascular health, and this is one of the situations that we see this. So again, in acute, we think of Staph aureus plus some others that can sometimes be introduced. And then in subacute, we almost always think of this Enterococci. Again, they have to be treated. So we need for there to be treatments. People who we know might be at more of a risk of this are people with poor oral hygiene or people with overall compromised immune responses. Maybe it is due to their lifestyle, maybe it is due to their lack of nutrition. It could be due to underlying other diseases like diabetes. And then we would want to give, before anything is done, before we know that these microbes might be introduced, like dental procedures or surgeries or anything that might be invasive, they will give prophylactic antibiotics before the procedures to try to knock down some of those numbers that might be introduced into the bloodstream during the procedures. Septicemia, we said, it is actively growing. Not just the presence of that might be transient, might come and go, but actively growing, multiplying organisms. They're using your blood as a petri dish. This is a very dangerous situation. Blood pressure bottoms out. That is the trademark sign of this. Blood pressure is dropping. It is lowering, and you're watching it do it. It's doing it pretty quickly. It's becoming what they call soft blood pressure. So as that is happening, we know the heart is having to work harder, and this can lead to cardiac arrest. So it is caused from this inflammatory response, and it is the most dangerous feature, and it culminates in death. When we look at some of the numbers in death, I think we have some of these numbers later, it's high, and you're going to see that. It is actually can be caused from a lot of different things, but we do know that, most of the time it's going to be bacterial. Rarely, about 10% can be fungal. Again, we only see that typically in immunocompromised patients to begin with. Polymicrobial, meaning more than one organism causing it, is now, we can see that too, but typically there's been some sort of massive trauma that has introduced that. When it is polymicrobial, there has been some sort of massive trauma that happened before that. When bacteria are involved and they are gram-negative, it can lead to what's called an endotoxic shock. Gram-negative bacteria produce an endotoxin, and so that when this endotoxic shock happens, it's massive, it's fast, and a high mortality rate, even with the best medical care. Gram-positive bacteria often can be similar to this, but it's due to their exotoxin, so it's a little bit of a different kind of reaction. Again, 20 to 50% mortality rate, and we're talking about with best medical care. So high, depending on what the etiology is, what the agents are, and it can be a lot of different bacteria that can cause this. Blood cultures are necessary to definitively diagnose it, so you have to end up getting blood cultures, but treatment's going to start right away. If there's any suspicion that someone is septic, treatment starts right away. As soon as the blood cultures are taken, they're going to do IV antibiotics, broad spectrum, so that no matter what it might be, you're trying to treat it. You can't wait for the definitive diagnosis. Can't wait. Gotta get those broad spectrum antibiotics on board, even though they have lower therapeutic indexes, which is going to be, tricky for the patient, but you've got to do it because the infections will kill them. So those are going to be the important things to do. Sometimes they actually even start those antibiotics in the bone marrow. So not just IV, they'll even do bone marrow antibiotics to get it even quicker. So once it is identified, then you can sometimes narrow down your treatment so that the therapeutic index is becoming a little bit safer for the patient. But in the beginning, you have to be covering all bases. Okay, so that's sepsis. The plague, this has occurred. The plague epidemics have occurred forever. The plague is actually what we call the plague, or the Black Plague, is actually from a bacteria called Yersinia pestis. Yersinia pestis, we do know, is endemic, so it's still endemic, even though we don't hear about plague outbreaks really any longer. But we understand that historically, the plague and the deaths and the devastation that was caused from the plague has actually shaped the society that we have today, because whole cultures were wiped out sometimes by this. We would have civilizations that would lose half of their populations during an epidemic of this particular outbreak of this bacterium. Now we have, for bacteria, we have treatment. We have antibiotics. Thank you, Alexander Fleming, for sort of starting that with the penicillin, but now we have all kinds of antibiotics. And we have treatments, and we have supportive care for signs and symptoms during acute illness. Still, though, we have some, occasionally, even in developed countries, even in our country, we will see annually someone who actually has infection with this. It's usually caught early. They look for it, they catch it early, they treat the actual bacterium, but they also treat signs and symptoms, supporting that patient until that patient can get over the illness. So there are different types of ways that this can be presented into the human body. So we understand that there's pneumonic plague, which is going to affect the respiratory system. This is the one that has pneumonic and septicemic going into the bloodstream. This is the one that has the highest mortality rates, obviously. Anything sepsis that causes sepsis. Bubonic plague is when that particular bacterium gets introduced through the skin, and it can move through the lymphatic system to a lymph node, causing that lymph node to really enlarge, and sometimes so enlarge that it ruptures and these are called buboes. These nodes that get really, really huge. So there's different descriptions that we have of this. Looking historically at the plague is kind of fascinating. It was devastating to cultures. People even back in the day, even though they didn't know what was causing it because they didn't know about the bacteria, but they knew that it was so deadly, and they knew that it was so contagious that this is kind of horrible to think about humans did this, but they would use people who were infected to go into their rival villages. They would send them in, sometimes even their dead bodies, into rival villages so that their enemies would, they were using this as a bioweapon even before they even understood what microscopic etiologies were causing it. Maybe not humans' finest moments at those particular times, but definitely something that we know happened. Bubonic plague, so mortality rates, even with treatment in bubonic, can be as high as 15%. Needs to be caught early, and treated early to be effective. Pneumonic plague, becoming systemic, pneumonia, causing pneumonia, becoming systemic, can interfere with coagulation, leading to what is called DIC, disseminated intravascular coagulation, which is then going to be widespread blood clotting, clots being thrown throughout the body, which means that then, because the platelets are being taken up and clots are blocking blood vessels, tissues start to necrose really before your eyes. You can actually see the tissues dying, and it's because the person would take on this visible darkening. It was called the Black Plague, this visible darkening of the extremities as it's progressing. And when that is actually happening in DIC, these widespread blood clots forming, people are actually losing the ability to clot where they need to be clotting. So then they would be bleeding out through the GI tract or the tear ducts or whatever. So death was happening because of a combination of different things. And so you can see where mortality rates, even with treatment, are very high in this particular 100% in without treatment, but even with treatment, still significantly high. So thank goodness we sort of control our, rats actually carry rat fleas, the fleas on rats actually can carry this, and it can be spread through that. It used to be, and this was a terrible thing, they didn't realize what they were doing, but they were so afraid of this in urban areas back in the day that when an outbreak actually occurred, they knew how much death was going to happen. It was going to be horrific. They would burn out the communities that had it, the buildings that had it, the people that were infected. They would, sometimes even with people in their homes that were sick, they would burn. But that was a terrible thing to do, because when they were burning, the rats were escaping. So what they didn't really realize that they were doing, that was not a good technique to control it, because then the rats were moving to uninfected areas, and then people would be getting it there as well. And sort of horrific but interesting history about plague. Again, this is a bacterium. It's Yersinia pestis. You can see it on gram stain here. So anyway, it's in a family of bacterium, the gram-negative rods, like Escherichia coli, Proteus mirabilis, Pseudomonas aeruginosa. So like many of the microbes that we hear about, but it can take very, very few microbes to actually, microorganisms, individual ones, very few, to actually cause disease. Again, the rat fleas were the principal reservoirs of that, and we understood that. Now, it's endemic in the United States, and so we know it's in these areas. The last cases that I followed were a couple who were from New Mexico who had gotten on a plane to New York, and their signs and symptoms sort of started while they were on the plane. And by the time that they got off the plane in New York, they were pretty sick, so went into, hospital there and was diagnosed really quickly and treated, and they survived. But that was the last cases that I heard about, but I'm sure there have been cases since then. That was a few years ago. Tularemia. Tularemia is going to be, and you can see, most serious forms of it. Francisella tularensis is the bacterium that causes this. And this can be a very serious infection. It used to, and it's still sometimes referred to as rabbit fever. We saw more of this when and again, this is the bacterium that causes it, Francisella tularensis. This is, the people most at risk for this are going to be hunters that are dressing their own meats, but especially certain types of animals. And I do think that less people now in developed countries are eating rabbits that are wild. Sometimes they are farming animals that they are controlling what those animals have, and they're testing those animals that they're not contaminated with these things. But we used to see a lot of this. Now the people most at risk for these are going to be people who are handling these types of animals. So veterinarians, farmers, hunters, these types of things are going to be the most at risk. Can be also, if there's high enough numbers of it, can be also transmitted through aerosol. So it's very, very contagious, and we know we need to be careful with that. So you can see laboratory workers, people who are working in microbiology, but also who might end up growing this type of thing, but people who are handling these types of fluids need to be careful. Lyme disease. Lyme disease is from a bacterium called Borrelia Burgdorferi. This is a spirochete. It is going to be transmitted through a tick bite. It causes a rash sometimes in people that is referred to as erythema migrans, which is a redness that's moving. That's what that would literally mean. Red that's moving. That's called a bullseye, gives a bullseye kind of appearance. If somebody had that clear sign, that is so nice, because then you kind of know what you're dealing with. And then you know that you can go ahead and treat it. This is a classic picture of a bullseye rash, which looks like a target site, doesn't it? But it can also look like this, because it starts out red here where the bite is, but then the redness dissipates and moves away from that. So here's another less classic than this one, but these are the kind of things that if you see, sometimes the people that come in that show you this, they don't remember having a tick bite. They didn't necessarily remember ever having a tick bite. It's not like they remembered removing a tick from this area. Most of them don't. Most people who have this don't remember that they had a tick. So it can happen without a known exposure to that. The important thing about Lyme's disease is that the treatment happened in the early stages. And it's antibiotic treatment because it is a bacterium, it's a spirochete. So if people can get treated, they can get better. And this is going to be an important thing for that. Now, if the treatment is held off, then secondary and third stages of this can end up involving the joints. It can end up having systemic kind of complications, so cardiac, neurological symptoms, even symptoms from the cranial nerve. So you can see crippling arthritis. So this can be not great if it's not treated early, and it's important that it does get treated early. Again, the bacterium is Borrelia Burgdorferi. It is a bacterium. It's really good at evading the immune response, but the good news about diagnosis on this is serological testing can be done. So looking for somebody who has IgM antibodies, really important. IgM class of antibodies are the first response antibodies. Seeing those going up is going to be that is your sign that that person has Lyme disease and needs to be treated immediately. You can also look for IgG if you think that you have missed the first stages of the first beginnings of this, and that can also be used for treatment. Control is being sure to be careful if you're in areas with lots of ticks that you protect yourself from tick exposure. It's called Lyme disease because of where it was first identified in Lyme, Pennsylvania. but it has pretty much moved now, and we are seeing cases. You can see cases even here in the deep south and even in more arid regions. So it's kind of all throughout now, but certainly concentrated in Lyme, in this particular area. Lyme, Connecticut. I think it's at Pennsylvania. So anyway, again, the good news is it can be identified in these early stages by sometimes symptomatic approaches. The treatment is not difficult, so tetracyclines, those types of things, just antibiotics in the first couple of weeks exposure. But if it's later, it might take serological testing, and then treatment can become a little bit more complicated. So Lyme disease. Infectious mononucleosis is something that is actually often called mono, or the kissing disease. Medical professionals are encouraged not to use that anymore, the kissing disease, because that can, it's interesting to me, but that somehow, for some populations, that can lead to a stigma, so this, I guess, anything that you can avoid as a medical professional that you think might be stigmatized by certain cultures or populations, like even saying sexually transmitted diseases, even though sex is an absolute necessary normal part of human development and whatever, that's stigmatized in some populations that are less informed about understanding how diseases are spread. Respiratory, it really shouldn't be any different from saying respiratory-borne diseases, sexually transmitted diseases, kissing, no more stigma. So, but that's not true. Some people really would. It can actually interfere with them even seeking treatment and seeking help if there's something that they feel this sort of stigma associated with it. So anyway, we call it mononucleosis. Now, most, not all, can be caused, this particular syndrome, infectious mononucleosis, can be caused by a lot of different bacteria and viruses, but the majority of them, we associate with the Epstein-EB or Epstein-Barr virus. That's the majority. It's in the herpes family of viruses, and most of us have had exposure to this before we were 5 years old. Most of us have been exposed to this before we were 5, and we didn't get very sick. And how we know that is by serologically testing populations and knowing that most of us have antibodies to this, and we didn't get very sick. But if you encounter this particular virus a little bit later, like right at puberty, even pre-puberty or adolescent, if that's your first exposure, this can cause a very serious illness, this Epstein-Barr virus. So what we call infectious mononucleosis is this pretty acute signs and symptoms that you see: sore throat, high fever. This is often, people think, well, that's what I feel like when I have Streptococcus pyogenes, a strep throat. They're very similar. You can have the lymph nodes, the very sore throat, pharyngitis, a sore throat, inflammation of the throat, fever, nausea. You can have all of those things associated with it, even a rash, like is associated with some streptococcal infection. So these, you need to rule out infectious mononucleosis if you're seeing this, as well as rule out Streptococcus pyogenes, which can do the same things. The fatigue, the extreme fatigue, is the hallmark of this. And again, it's because the spleen is working overtime, the liver's working overtime, they're responding to this, they're enlarging. And you have to be careful with people who have this, because for weeks and months, they can be at risk for any kind of, you tell them to limit their physical activity, because if they had a fall, or if they had, if they were playing sports and somebody, bumped them, I don't know, they tell them to really limit it for months, a few months, because the spleen can rupture. And the liver can be damaged as well, because both can enlarge. So again, most of us had this, and we didn't even have any noticeable symptoms. But if you get infected later, it can cause serious symptoms. So, so it's important to note too that this Epstein-Barr virus, that we do note in people who had serious disease with this. We're seeing that there may be some correlation to them later on in life. slight correlation. Study still ongoing, but one retrospective study that was just recently done that is being supported by peer review is suggesting that those people have a higher incidence of developing an autoimmune disease we call multiple sclerosis that ends up attacking the oligodendrocytes, those glial cells in the central nervous system that provide myelin in the central nervous system. So multiple sclerosis is an autoimmune disease that we see typically happening in people from onset 20 to 40 years old, typically can be outside of that range. And for some people who get diagnosed, they can have pretty rapid progression of signs and symptoms that are hard to deal with. Some people, they go in and out of remission with it, but some people can have a really hard time with that. And they do think that people who have had this exposure with serious illness earlier in life have a higher incidence of that. Again, we know that there's some viral infections that can precipitate things such as cancers and other autoimmune diseases. Just like we know that type 1 diabetes, which is only diabetes mellitus, which is only 10% of diabetes mellitus, but that type of diabetes mellitus, type 1, is associated with having a prior viral infection that caused your immune system to produce antibodies that attack the beta islet cells of the pancreas that produce insulin. So this is a similar kind of cross-reactivity we think might be happening. Okay. Again, if somebody is having symptomatic acute illness from this, then that spleen and liver we do need to be concerned about. And, occasionally the spleen will rupture. It's pretty rare, but it can happen. Now, the next diseases we talk about, hemorrhagic fevers and non-hemorrhagic fevers as well. But the hemorrhagic fevers are the ones that will cause your blood vessels to loosen for you to start bleeding out. So the ones we're thinking about, these are the geographical distribution is dependent on where the host lives, right? So we're going to talk about a few of these. And we understand that what happens is this virus, when there's a viremia event happening, it causes those capillaries to become fragile. And the blood clotting systems are also affected. So this is what can lead to such devastating kinds of hemorrhaging, bleeding out because of these viruses. I think everybody has heard of Ebola. Ebola is, there are different variants of Ebola, this particular virus, but this has an incredibly high mortality rate, even with trying to do supportive treatment. This has a really high mortality rate. So when we think about Ebola, we hear about certain variants of this having up to 90+% mortality rate. So no matter what you're doing, you're still going to have, more, about 9 out of 10 people die. That end up encountering this. Ebola is actually, we know, is endemic in certain areas. It started in the first that we noticed were in the central regions of Africa. And, what happens is the World Health Organization and CDC professionals located throughout every country are looking for these medical professionals, are looking for people who have the signs and symptoms of this, and they quarantine those areas down immediately. No choice is involved. It's by military mandate, they're quarantined down because of how serious this is, and this is what we're glad of, that this happens. But anyway, there are others as well that are hemorrhagic. Yellow fever, chikungunya, this is one. Dengue fever is another one. And these are spread, the ones that we're seeing here are spread by mosquitoes. So yellow fever, Africa and South America, dengue fever, Southeast Asia and Africa, chikungunya, this is endemic in Africa. So, they're located by, we think about them by regions. The Ebola, we said, Ebola can be some of the variants up to 90% mortality rate. Some of Lassa fever is one that is asymptomatic in a lot, but Ebola and Marburg fevers, these are very serious. We do know bats are thought to be a natural reservoir of this, so if anybody's interested in a book, it's called Hot Zone. It reads like it's fiction. It reads like the most exciting, scary infectious disease novel you've ever read or movie you've ever seen. But it's called Hot Zone. It's true. It's absolutely true story written by a journalist, Richard Preston. And I really always recommend for people to read that if they can, because it gives you an idea about what we're dealing with when we think about diseases that have such incredibly high mortality rates, and just what would happen if these diseases got out of the quarantined areas. So The Hot Zone by Richard Preston, I really would recommend anybody who likes to read that. Non-hemorrhagic fevers, obviously we think about some of these as you would initially think, okay, well, these must not be as serious, but some of these are pretty serious, and some of them have a significant mortality rate. The bacterial causes, this is a list of some of the bacterial causes. Rocky Mountain spotted fever is one that many of you all may have heard about because it's endemic in this region. It is caused from a bacteria called Rickettsia rickettsii, that is on your list. You have maybe also heard of cat scratch fever. You thought that was just something your grandmother told you so you'd stop messing with the kittens. But actually there is a disease, and it's caused from a bacterium, Bartonella henselae, that is also on your list. These two are not as common, but brucellosis is one that, again, dealing with animals might be a higher risk of that. And protozoa babesiosis is one that is a protozoa that can cause a non-hemorrhagic fever disease. So brucellosis is one that when we think about it, again, in livestock, this can lead to stillbirths, if you will, because placentas become infected. Brucella Abortis is the name of that particular bacterium that we think about with that. But you can see what's on your list there. I'm just going to refer you to that. These are some of the species of Brucella that we can see that can even cause disease as a zoonotic disease, can be transferred to humans. It's pretty rare that happens. Again, you would have to have had an occupation or exposure that could give you that. So I'll let you look at that on your little list, etiologies list. I'm not even sure I have Q fever for that on the list, but I might have Coxiella burnetii. I may have that in there. I don't know if I even put that on there, but I'll again let you read the pathology that you would want to know about that if I had that on there. I do have Bartonella henselae. This is pretty common. It's actually very common. It usually just doesn't cause that serious of disease. Most of us have been exposed to this in our lifetimes. Most of us have held kittens, have been scratched by kittens and cats and whatever, and so we have some antibodies to this, which means we've been exposed. We wouldn't have made the antibodies unless we've been exposed, and it didn't cause any problems for us. In some cases, and you see it's not that common at all. In some cases, what we'll see are enlarged nodes that are so enlarged, lymph nodes that are so enlarged that they do seek out treatment for it. And sometimes the nodes have to be opened up and sometimes even removed. So typically what we see it are, a child will be brought in or an adult and they'll have scratches, and you'll say, well, here's a lymph node in the elbow or lymph node under the arm that's really swollen. So you look below that site where that lymph is being transported back through the lymphatic system to the subclavian vein, and you note on their extremities that they have an injury or injuries due to a bite or scratching or whatever, and you ask about it. And if the node is large enough, you may biopsy it or may even remove it if it's large enough. And certainly if there are other symptoms as well, this can be identified as the causative agent and can be treated. So again, you can read through that. and it's not as uncommon as you would think. Ehrlichiosis is a disease that is caused from Ehrlichia, which is a small, very small intracellular bacterium. So this can be a little bit more difficult to identify definitively. So sometimes you have to wait so that you can actually see it through serology, indirect serology testing. Indirect because it's not always easy to pick up on direct serology. The indirect serology tests sometimes are going to be our best bet. But again, just routine treating with antibiotics, especially something like the tetracyclines, doxycycline family, is going to be one that you would want to do. Anaplasia, this is another one that's very similar to Ehrlichia and whatever, but again, same kind of treatment. Sometimes when people come in with these types of symptoms, sometimes they're actually, if they think there's any sort of risk that they may have been exposed to these ticks, so they're outdoor people, they're, whatever, they're going to go ahead and just, without even doing this, because the treatment sometimes is less expensive, less invasive, less whatever, than going to the, the whole 9 yards to get the ID. They're just going to treat and hope that it all resolves, and oftentimes it does. So that's what the treatments are for that. Babesiosis, again, caused from a protozoa, Babesia, and combination treatment with antiprotozoals, which you all know means that they're going to have lower therapeutic indexes. So this you would want to, before you treat somebody with something with a low therapeutic index, you want to have definitive diagnosis. Yeah. So different kind of treatment. Rocky Mountain Spotted Fever, again, Rickettsia rickettsii, I'm sure that'll be on the next slide or two. There it is. It transmitted by ticks. What this can give, doesn't always, but what this can give you, and it is endemic in this area, what this can give you is a petechial rash. So you'll see this rash that can be all throughout the body. Again, transmitted by ticks, all throughout the body. You don't have to have had a known tick bite. You don't have to have, but this can have a high mortality rate if untreated. So and even treated, look at this. This is still high. So it's important to get this diagnosis quickly, and it's important to be aggressive in the treating for this. This can be really important to do. One of the last patients I saw with this, it was too late. When she came in to the clinic, she had this rash all over her body, including her palms and soles of her feet. Oftentimes if you see something on the palms and the soles of the feet, that's also a clue that this is really invasive. And by the time treatment was started, it was really too late for that particular. She was in her 40s. She was a polo player, very active, athlete. Traveled, was outdoors all the time. Had no known exposure to a tick, because she was asked that when she came in. And she said no, had not removed a tick. We couldn't find a tick, and she had not removed one. But that is what it ended up being as her cause of death. Chagas disease, Chagas and African sleeping sickness, these are caused from the genus Trypanosoma. Trypanosoma is a protozoa. When we think about Chagas disease, this is often called the AIDS, the new AIDS of the Americas. This has a really long incubation time. It can be really difficult to cure and treat. It is from a protozoa. So there's no known vaccines for this or whatever. It's just protection against getting a bite from the bug that can actually lead to this. So understanding the risk of traveling to these areas where it's endemic, and then being very careful to not have, to protect yourself from these bugs. These are sometimes referred to as, it doesn't say it in your notes, but these are called kissing bugs. I don't know, because I think sometimes the bites are really close on the face and or neck or area. I don't know, we had learned that back in school a long time ago. But anyway, just being careful when you go to these areas where these vectors are, that you are, careful of that. So anyway, Chagas disease and African sleeping illness. That is, and you can see that's actually the species Brucei. This affects the central nervous system, making the people they're said to be walking around. This is in northern Africa, and this endemic to northern Africa. This is said to make people walk around like they are zombies. And again, high significant mortality rates. Anthrax, we know, is actually caused from Bacillus anthracis, which is a bacterium. Again, on your chart, we learned that Robert Koch, with his Koch's postulates that he came up with in the late 1800s, are still being used today to help to identify etiologies of diseases that we don't know. So when we're trying to find out what something's called, what is the etiology, we will use Koch's postulates to still logically identify what those etiologies are. So he gave us those along with helping to accept the germ theory of disease. Anthrax we really do think about as being a zoonotic disease. Unfortunately, the toxins are so powerful with this respiratory-borne anthrax. It has a really high mortality rate, and so we have to be very careful in understanding that this could be used as a bioweapon, meaning that someone who doesn't have very good intentions could use this to try to really, I guess, kill people, kill whole populations, really. So anyway, so you can see what some of this can do. So y'all can look at this Bacillus anthracis. This is what it would look like on a gram stain. It does have spores. Not all bacteria produce spores, but Bacillus does, and Clostridium does as well. Okay, so again, there's different variants, cutaneous and systemic, and you can look at some of those. I have a lot of slides on anthrax, obviously, and treatment. It's a bacteria, so if we can diagnose it early, we can try to treat. But again, if it's become systemic, it's really difficult. So love these little slides at the end of your chapters where they kind of put everything in a nutshell, and they're color-coded by what group they belong to. The reason the group is important is then we know how to effectively treat. So this is why this is important, but I kind of like these visuals because even after you go through and listen to some of these, this can sometimes be something that will help you to retain the information. I hope you stay well. Thank you for your attention, and I will see you on the next topic.